So we are, I think, obviously very excited to have John this afternoon. John Parker is a psychiatrist in private practice in the southern suburbs of Cape Town, but he's spent a lot of time working in the public sector at Lentegé Hospital, and he's was one of the first psychiatrists in South Africa that was really passionate about the recovery movement in mental health. And he was the recovery guy for many years. And the recovery movement is, as you guys know now, particularly I guess people in Boston, is really about that people with severe mental illness like schizophrenia and bipolar can live meaningful lives. And so the project that he started at Lentegé Hospital with other colleagues that he's going to be talking about today, I think is on that backdrop. And obviously, we're also quite interested and is fitting for the theme that it's about greening of hospitals. And so we're looking forward to your talk. John, please go for it. Thank you.
Thank you. Hello, everyone. Yes, so I was a little bit surprised that, to see the title of my talk in the program, because I just thought I was talking about the Spring Foundation, which involves sustainable and green spaces, but quite a bit more. And hence I thought, and especially in the light of what Professor Atwoli had to say to us earlier about the effects of colonization in particular, I thought this slide was an apt place to start, because to me, the interesting thing about colonization and what I suppose my ancestors did all over the world, I think was actually something we started doing to ourselves long before. And one of the instances of that is the origin of psychiatric hospitals. So this is a little bit about that story, and about a response to the problem of institutions. So Lentegé Hospital, that's the main gate. And the only other place you'll find a main gate like that in this country is the entrance to a prison. And I always ask people, how would you feel if it was the worst day of your life, which it probably would be if you were about to arrive there for care, if that's what you were confronted with as you arrived. So Lentegé Hospital is one of 3 large psychiatric hospitals on the Cape Flats, large institutions, and I worked there for just under 20 years. And in a sense, this began with really my own challenge to survive in that environment and to find hope and some way of moving forward. And really, just as these thoughts were kind of coming together, I got invited to Boston University, where I learned all about recovery. And yeah, so for me, the key thing about recovery is actually it shifts our thinking about mental illness from a binary idea of mad or normal to process about finding meaning and purpose in our lives, something that actually we're all challenged with. There are various conceptual models. I like Jacobson and Greenlee. Key internal conditions required a hope. This idea of healing, which, by the way, comes from the Old English to make hale or whole. Empowerment and connection. Yeah, and it was quite notable in terms of thinking about colonialism and how much disconnection took place. And of course, this is has to be in an environment of human rights and a positive culture of healing in order to have recovery-oriented services. And as many will know, this has really become a fundamental principle in the design of health services in many countries, and hopefully something we should be aspiring to. But what do we do about the institutions? So that's Lentje, and that's pretty much what the whole place used to look like 20 years ago. Very few trees, very little except high fences and locked up drab buildings. It's now got 660 beds. It's one of 3 in the Western Cape, various sections. It was initially built in 1986. That was the heart of apartheid's tricameral project. This was an experiment where the apartheid government thought that they could move all what were called black, so African people, into homelands that looked like it looked like someone had spilt some paint, and not very much paint, onto the map of South Africa. And those were called independent homelands. And then within South Africa, the imagined South Africa of the apartheid government, there were 3 houses of parliament. One for white people at the top, of course, one for so-called colored people, and one for so-called Indian people. And the idea was that each of these groups would have their own set of services, their own health departments, their own schools, and so on. And Lentje Hospital was the model psychiatric hospital for colored people on the Cape Flats, which is an area where most people of color had been removed out of Cape Town, where they originally lived. There's severe poverty and social fragmentation in these areas in Philippine Khayelitsha, up to 50% female-centered households, high unemployment rate, very low incomes, and huge levels of food insecurity. And then there's the broader problem we all know about. In the 2003 WHO survey showed 1 in 3 South Africans in their lifetimes will suffer from a treatable mental illness. Yet only 1/4 seek treatment, and only 11 actually get any form of mental health services. We know this is increasing globally, a whole lot of major drivers. I did some work a couple of years ago looking at the demand in the Western Cape, and if we use every bed to full capacity, we still have less than 50% of what is needed simply for acute admissions. We all know the stories. Mental health care stigmatized, underfunded, and we're still stuck with this problem of centralization in large institutions that remove people, that were designed to remove people from society and do no more. Built like prisons, because that is how this was thought about. And the people in those places are forgotten. Simply, and do not, by the way, in this country, where there is universal franchise, even for prisoners in prisons, people detained, this is the word of the law, in a psychiatric hospital or declared mentally unsound, very antiquated language, may not be registered to vote. So to quote Albie Sachs from the Constitutional Court, these people simply do not count. So we have this problem of the institutions, and I would suggest it's a legacy problem for all of psychiatry, because psychiatry was born in the institution. There was no practice of psychiatry before the institutions. The APA was actually originally known as the Association of Asylum Keepers of America. These large, centralized, isolating places that invoke suspicion and fear away from the public eye. So all sorts of things happen in these places that nobody knows about or wants to know about because of the stigma. But the problem is they're cheap. There's a problem of economies of scale. It's always going to be much cheaper to detain large numbers of people in big warehouses than to give them the care they need. And that's the reality we're facing. They're built primarily for security with this idea that mentally ill people are dangerous. And where did all of that begin? It's interesting, the first records we know of institutional care of people with mental illness was the Cairo Bimaristan in what was then the Ottoman Empire. And what's interesting about the European records of this time is the surprise with which the records note with surprise how well treated the patients were in the Cairo Bimaristan. The first record of a Western institution was the Priory of St. Mary of Bethlehem. If you're ever wondering the origin of the word Bedlam, that's where it comes from, and began admitting what they referred to as lunatics in 1377. Well, what's quite interesting is for 200 years, that didn't really change. So 1700, 500 years nearly, the Bethlehem was still the only state institution in the UK. And then something happened. 1750 to 1820, 16 public institutions sprang up. By 1847, there were 5,000 plus patients in 21 asylums. By 1914, there were 97 institutions with over 100,000. And this institutional movement really peaked in the United States in the 1950s, 500,000 people detained in psychiatric institutions. So what was happening? Sorry, I'm a little bit lost. Yeah. There was care before the institutions. Their records, this is just one example, there are various models, but it wasn't as if there was no care. In New England in this time, it seems there was records show quite a high level of acceptance of people with mental illness in communities. And what's more, an understanding that people could be temporarily mentally ill and then return to society, even if this happened more than once. There's a record of a mayor who occasionally needed care and then returned to his job as a mayor. There's more than one record of a parish priest needing care and then returning to the role and needing care again. And there were mechanisms for that temporary restriction of freedoms. Obviously, this wasn't ideal either, and in fact, Dorothea Dix, who was really known as a reformer and a campaigner for institutions, actually wrote a lot about the evils of this system. So clearly it wasn't ideal, but yes, there were alternatives. So why did they grow so much? Well, the big theory is that the more we provide a place to, because let's be honest, living with someone with mental illness, dealing with mental illness is not an easy thing. It's a challenge to all of us. So if there's an easier way, people go for it. And that easier way was provided by the asylums. And society, with this easy way to throw people away, society gradually became less tolerant of those considered to be difficult. And the other thing that was happening was industrialization, urbanization. So it became much harder to fit into the workforce. It's one thing to look after a herd of cattle with mild or quite severe mental illness. It's another thing to sit in a production line and do exactly the same thing all day. So society becomes less tolerant, and there's an easy way to put them away. And then we got, this was all happening during the European Enlightenment, the age of reason. And of course, Foucault argues that the unreasonable in society became unacceptable in this obsession with reason, reason and the individual subject. So this legacy, this culture of divide and rule has been within European culture since Industrial Revolution, the European Enlightenment, and really spread from there. Some things we really benefited from. Scientific thinking was a product of the same culture. And so it's wasn't all negative, but some very dangerous effects from that culture. And yeah, psychological medicine then had a place to flourish. So psychiatry, our legacy was born in these institutions, and we need to take ownership of that and challenge it. But closing institutions isn't so easy either. As was shown in the Life Esidimeni disaster a few years ago in this country. The Gauteng Health Department decided that the institutional care of mental health care users was costing too much, and they very quickly planned transfer to small hospitals and NGOs, didn't really work out the funding models, didn't really work out the oversight, and within 2 years, at least 140 of those individuals had died, and there's still over 40 who no one can trace. No idea what became of them. And so this is the tough reality. We've got these places. In fact, at the moment, there's a reversal of deinstitutionalization in the Western Cape because they're just not coping with the demand. So what do we do with them? And that's really where the idea of Lentegeur Spring Foundation came from. So Lentegeur actually has meaning. Lente means spring, and geur is the aroma of spring. And the idea of the Spring Foundation was to try and find a way forward, a way of putting the institution recovering. Because the thing about these institutions actually is they are also resources. There's nowhere in Mitchell's Plain that's as safe to walk around on as the grounds of Lentegeur. There's nowhere that has as much open land, rooftops for solar, water catchment, accommodation. So are there ways we can think about these institutions differently to evolve them? And that was really the thinking behind the Spring Foundation. The essence of spring. And in the beginning, we try to keep it deliberately metaphorical. And for two reasons. And the one was because what I realized after working there for all those years is most people who work in an institution are not proud of how it works. And most people working in an institution have ideas about how it could change and improve. But what happens in an institution is you become institutionalized. The way the institution has to work because of its limited resources, because of its obsession with detention and safety and danger, and this idea of danger, crushes other initiatives that involve being brave and taking chances and putting your faith into so-called mad people. And so we kept it deliberately metaphorical. We said, well, spring is about hope and recovery to most people. And if you understand that, if you believe that, then it's also about connection, because spring is part of the cycles of nature. And if it refers to us, then we are part of those cycles. So hope and recovery through reconnection was really the metaphorical origin of the Spring Foundation. And the importance of keeping it metaphorical was because that allowed anyone in the institution to come up with an idea. And as long as it was about hope and recovery and reconnection, we would support the idea as the Spring Foundation. So we developed it as a not-for-profit public benefit organization, which to facilitate hope and recovery through reconnection at Lentegeur. We have a number of active projects running, and then various ones that kind of come and go, short-term projects that we try to support. Yeah, the active ones are really the ones that have proven sustainable, and we've kept going. Probably the simplest example of this concept is the ID project. So many people arrive at a psychiatric hospital having lost everything, including sometimes their identities and often their identity documents. And in South Africa, if you want to get access to accommodation, to a disability grant, to any form of state service, it's a lost cause if you don't have an identity document. Getting an identity document costs 180 Rand plus about 40 Rand for photographs. The health department decided they would not fund this because identity documents are not part of healthcare. So we had this bizarre situation where people were staying in the hospital at a cost of more than 1,000 Rand a day because the same department spending money on that would not fund ID applications. So we stepped into the gap. We fund our ID applications. A simple document that reconnects you to your rights as a human being, bringing hope and a chance of recovery. So yeah, for me, that's the simple example I trot out every time, the principles. Probably our flagship project, and I think what Bonga had in mind when he asked me to come, is the market garden. This is a 1.2 hectare piece of land that is a working organic vegetable garden. The produce is sold to various organic retailers, as well as excess produce goes to food kitchens. Some of it is bought by the catering department at the hospital. I must admit, originally, I had dreams of everyone who worked there starting their own little market gardens at home, until I realized that many people didn't have any ground at home. And actually, we realized what this does more than anything is it makes people employable again. It gives people a sense of hope. Walking around in the garden, I'm sure those who came to the visit will agree, it's just this place of tranquility and solace in the middle of this institution. And staff go there at lunchtime just to sit, and it's the one place in the hospital you hear the birds singing. It's cool, it's green, and it's beautiful. We have about 20 patients working there at any one time in the garden, and they all earn a stipend, and then they get financial literacy training as well. We help them to open bank accounts, and suddenly we see things changing. There's now a big waiting list in all the long-term wards, because the staff of all those wards are forever asking, please can this guy come to the garden? Because they've seen the difference. People working in the garden go home that much sooner. As a forensic patient in particular, one of the things you have to prove to be discharged is employability, and this provides that. Garden provides that. In our intellectual disability section, we run a wheelchair service center. Similarly, these are all long-term intellectually disabled individuals with often severe intellectual disability, who were simply sitting in wards doing nothing all day. Now they get an opportunity to go to work, to feel that their lives have got meaning and purpose. They earn a little bit of money and get to go out on shopping excursions, and for the first time in their lives actually own something, understand what it is to have possessions, to save for things and hope for them. We have others. There's an emergency medical service depot next door, and they came on board, and they take 6 to 8 patients to work there at any one time. Gradually, what they do has been upgraded, and they're learning stock control, and a whole range of clerical processes that is making them able to prove that they're employable and able to leave the hospital with a little CV, proof that they can work and a chance to get further jobs. We run an ironing project. So a whole range of vocational training projects that we're expanding all the time, looking for opportunities. The hospital has just come to us with a whole range of internships that they want to develop for patients at the hospital, opportunities to work. And so wherever we can, there's a car wash, any opportunity to both earn a little bit of money and just feel like you're doing something relevant. And the other big problem we have is people with nowhere to go. As you can imagine, anyone working clinical work just balks at the idea of discharging people into the street. So that's a huge struggle. And the Rose Parent Project is an amazing project that actually had developed before the Spring Foundation, but joined us because we developed the Spring Foundation as a fundraising vehicle. This project involves volunteers from the community who volunteer to take people with mental illness who are ready for discharge into their own homes, people who've got nowhere to go. It's I think one of the most beautiful concepts and scarcely believable that you know, there are, in the face of all this stigma, there are people who come forward and say, I will accept this person who has been rejected by everyone else in society, and I will give them a home. It's still small time. We've got 8 Rose Parents, but we're now helping these Rose Parents develop group homes, which are officially licensed homes that can take more than 5 individuals. And we're also looking at the redundant nursing home, nursing residence at Lintier Hospital as a potential opportunity for accommodation that will then be on-site, available with vocational training and a whole huge opportunity to go forward. So in all these ways, we're really looking for ways to evolve the institution, to try and change that idea of what these places are and what they do. Various other initiatives, so the rooftops, there's a huge amount of water collection. There's a huge potential for solar electricity generation that could be funding these initiatives, could be making. You see, if we really use our imaginations, we can use these resources to actually address the financial problem we're facing as well, and create an idea that these are places of worth, that these are places of healing and recovery. And yeah, so I'm busy discussing in conversation with someone from the World Bank who's looking to fund green projects that are related to community and upgrading. So there's great hope that we'll be able to put something together involving electricity generation and funding for other projects. We've run mindfulness programs for staff, various programs supporting staff, so to help people to get out of the siege mentality, to feel looked after themselves. So support. We've done a lot of work on the gardens and landscaping in the project, just to change how it feels from the sense of a prison to something that looks beautiful, where things can grow. We've got a proposal for small container gardens for patients when they're discharged, and then researching whether that actually improves adherence and follow-up, and various other projects. I mentioned the right to vote earlier today. That's something we're campaigning for again. We did with the last elections in this country. In fact, that legislation prohibiting people in psychiatric hospitals from registering was actually removed from the Electoral Amendment Act and at the last moment reinserted by the former Minister of Home Affairs because he felt it was an affront to the parliamentarians that mad people could be allowed to vote for them. Yeah, that Minister of Home Affairs was since disgraced and not part of our government anymore, which is interesting, along with a few others. Yeah, but that program we're getting up and running this year. And I think if nothing else, it's promoted a different idea of the hospital. It's grown a different image of Lentegeur Hospital. And if nothing else, it's helped the people working there to see themselves differently, to believe that there is hope, there is something you can believe in a place like this, that you can believe in yourself. This was a lovely artwork project where we got graffiti artists to work with youth at the hospital and design a mural. Yeah, the words on it, it's a lovely picture of a kind of rainbow and a rough storm. And the words these adolescents chose for the mural was, "The storm always passes." Yeah. So, yeah, continuing, still media interested in it all the time, a few articles this year. We've had a couple of master's projects and one PhD project on recovery, looking at the Spring Foundation's work, but much more to do on that level. I eventually resigned myself to the fact that I'm not a researcher, I'm simply an activist. Yeah, and almost 10 years down the road, we've secured an anchor funder for the next couple of years, which brings our total funding to over 10 million. I know that's not very much in dollars, but it means a fair bit here. We employ 4 individuals. Increasingly, the hospital administration sees the Spring Foundation as a key resource and provides support. Yeah, at last count, we brought some additional services to over 500 patients who've been in the hospital. Yeah, quite major media presence, and hopefully we're creating a blueprint for the redesign of the institution. But of course, it's an uphill battle. Financially remaining sustainable is difficult. Proving this concept to the health department is a huge challenge, and we haven't really got them on board with funding just yet. Keeping it alive in terms of staffing is a big challenge. Maintaining fundraising, we're completely donor dependent. And simply convincing mental health care workers in this country that recovery is a concept that is believable is quite a challenge. And especially in the face of what we're seeing at the moment, which unfortunately is declining services, declining funding in mental health care. And of course, the reflex action is put them back in the institutions, because that's, to put it very crudely, that's the area of least risk in terms of litigation against the health department. Nobody sees what goes on there, and people are too ashamed to talk about it. So that's the Spring Foundation. In some ways, I so often wonder if it isn't a pipe dream. But then I remind myself that if nothing else is important in our world and in mental health care, keeping hope alive is critical. And so if nothing else, we're going to keep hope alive. Thank you.
Thank you very much, John. Are there questions for Dr. Parker? So, we'll get the mic. Do you have a mic there? Whilst Tay's getting the mic, maybe I can ask the first question, John. Or is that a mic?
It is.
Here's one. Yeah. You can give it to her. Yeah, just about connections. My question was about connections, and obviously it's part of your philosophy. But I was just wondering about on this continent. Are you aware of other projects that are doing similar work? Have you connected with them? Are there any ways of kind of trying to facilitate that through the institute? Yeah.
There have been a few connections with. So I'm just trying to think. Yeah, Fort Napier, one of the hospitals in the Orange Free State. There've been kind of connections here and there, but no lasting collaborations at this time. I have heard of various people trying to start similar initiatives, but not beyond that. To be honest, just keeping this going has really been enough of a challenge without being at this point managing to spread it further.
Yeah, no, I was just thinking about scalability, those kind of things of kind of how if other people can try and replicate the work and that you do. Dr. Mafuze, do you want to ask a question?
Yes, thank you very much, Dr. Parker. Bongi Nkosi Mafuze, I'm a registrar at UKZN. Two quick questions. First one, you mentioned that recovery is sort of like in a continuum. So when you look at the definition of health, according to WHO, they're saying health is a complete physical, mental, and social well-being, not merely absence of disease. So I would just like to hear your comment on that in terms of looking at recovery in a continuum. Can we ever achieve health as a complete physical, social, mental well-being? That's the first question. Second question is around the market garden. Do you have any exclusion criteria for which patients can come into that program? Because I'm just thinking, looking at how rife unemployment is, we may find patients keeping themselves longer in hospitals just so that they can get this income and support their families. Thank you.
Yeah, so to answer the first question, I don't think any of us can ever claim to be completely healthy. I think I see life as a journey of becoming more whole, more fully ourselves. So no, and then we die. So no, I think complete is very idealistic. I can see the sort of philosophy where it comes from, but I also think it's particularly important in mental health care to acknowledge that none of us are totally healthy, that we're all on that journey, and I think that's one of the beauties of the concept of recovery. We're all looking for meaning and purpose in our lives. Or more meaning and purpose. Yes, and I think that's very important to acknowledge because it removes us from this disconnection between them and us. And I've forgotten the second question.
About exclusion criteria for people that cannot.
No, so Well, there's actually a smaller garden where people, a starter garden, that is run entirely under clinical care of occupational therapists. And it's really, you've got to graduate from that one to get to the big one. It mostly in the garden are forensic patients, who in this country, to become a forensic patient, it's not for shoplifting. It's for kind of serious crime. So that was pretty scary for the hospital to imagine that we would have these individuals, many of whom had committed serious violent crime, walking around with machetes and hoes and spades and various other weapons. So they're vetted first, but we to date have never had an incident in the garden where they are only under the supervision of the gardeners who are employed by the Spring Foundation. So that was quite an experiment in itself. I haven't encountered the problem of, they do only receive stipends, so it's not quite a full salary. We calculate that according to what we believe an able-bodied, how many of our patients do the job of one able-bodied person, and the stipend is, at the moment, it's kind of 2 to 1, so a stipend is half of the minimum wage of a farm laborer. So it's kind of, no one's going to make a fortune there. It's amazing, you know, what's lovely to see is people going home with money, and that sense of value when they go home for a weekend or something and bring gifts and money home. But no, I haven't heard of anyone asking to stay in hospital so that they could stay in the garden.
Thanks, John. Siggy, one last question I think we have time for.
So thank you very much, Dr. Parker. You took us through a very nice kind of introduction and maybe a tour through from the origins of the gruesome sort of institutional care through to deinstitutionalization and some of the instances where it kind of went lopsided, like in our country, and to now where there's kind of a move towards reinstitutionalization. I think you're kind of presenting the recovery model as perhaps an alternative to the absolutes of, okay, it's either institutional care or, non-institutional care. The example that you're presenting in Lentegea has a large forensic population, which one might argue that, could have to do with maybe the criminalization actually of mental health, where perhaps as a consequence or a back result of patients with serious mental illness not being in institutional care, landing in the forensic system. I guess I'm making this question, I'm posing this question to pick your brain, to kind of ask what your thoughts are, what a model that could be fit for purpose would require of our health system. You know, so how we could get to a model that's not either or, and that doesn't put our patient with serious mental illness on the back foot when it comes both to access of mental health care service and to gainful occupation within their context, which I think is a lot of what the work that you've been doing incorporates. I know it's a bit of a broad question. I'm not sure if you're comfortable to tackle it a bit.
Not entirely. I think it's a long conversation, but a couple of thoughts on that. I agree with you entirely. I think there's actually data in the United States of how the prison populations increased as the psychiatric hospital populations went down. So I think absolutely. I don't know what the full answer is, but I think a good beginning would be turning the institutions into recovery centers. I think the institutions need to be in recovery. That's really how I think about it. And is it, the question, I think these are resources, are potentially resources in our communities. And we, instead of, I think we should be building from there, put it that way. Thank you.
Right, thank you so much. Thank you very much, John.